Dr. Nimrita Gyanchand.
Good afternoon, everyone. Thank you, Scientific Committee, for giving me this opportunity. I will be talking on early interventions for various bleb by the means of ocular massage, suturalizers, and any add-on injections of various antimetabolites when and how. So, after a successful trabeculectomy surgery, only half battle is won. Managing patient post-trabeculectomy is really an uphill task. Frequent monitoring is often needed to identify the bleb morphology, which provides an opportunity to modulate it. So what is an ideal bleb? An ideal bleb should be shallow, low-lying, pale, limited to upper eyelid, and with rapidly developed epithelial microcyst. There are various factors associated with filtration failure, such as younger age, higher IOP, diabetes, any prior ocular surgery. Other factors associated with filter failure are neovascular glaucoma, aphakia, trauma, or any prior disturbances in blood aqueous barrier. Wound modulation during filtering surgery can be done with antimetabolites, its correct placement and timing, proper timing for post-operative suturalizers, watertight conjunctival closure, and appropriate post-operative management. For a successful filtering bleb, there are various preoperative, intraoperative, and post-operative measures. Today I will be talking on post-operative measures. If nothing works, then bleb needling is done. There are various classifications for bleb. Most commonly used is Indiana bleb grading scale, which helps us to understand the clinical appearance of the bleb and helps to modulate for the bleb survival. The most common step for trabeculectomy failure is to recognize a failing bleb. So what are the signs for failing bleb? It can be flat, highly vascularized, localized, loss of microcyst, and can present with normal, high or low IOP. So initial few weeks are really critical. Often a failing bleb is preceded by a gradual increase in IOP, and there are various changes in bleb appearance. It is less diffused, highly vascularized, flat, and later with increase of fibrotic tissue it can be elevated or dome shaped, and finally it eventually leads to a tenant cyst. The most common cause for trabeculectomy failure are subconjunctival fibrosis and subtenous encapsulation. So bleb capsule, scleral flare or sclerostomy are the various sites which can cause bleb failure. Coming to the stepwise management for failing bleb, initially you should increase the dose of topical steroids, followed by ocular massage or subconjunctival antimetabolites injection, then laser suturalizers, and if nothing works, bleb needling is done. So what is the role of topical steroids? It helps to increase the success of glaucoma filtering surgery, helps by decreasing the wound healing response, and also helps to maintain an open fistula. On the other hand, cycloplegic helps to decreases the inflammation and also helps in deepening a shallow anterior chamber. Digital ocular massage is really an underestimated procedure post trabeculectomy surgery. So how it is performed, this is a video showing. We ask the patient to look down. It is not playing. We ask the patient to look down inferiorly and with a just lateral to the bleb. By the means of index finger, we give a local digital pressure. For early failing bleb, 5 mg of 5-FU fluorescein can be given by 30 gauge needle subconjunctivally 180 degree away from the bleb. But beware, it can cause corneal epithelial toxicity. When the patient presents with high IOP, a flat bleb and deep anterior chamber, laser suturalizers should be considered. When trabeculectomy is performed without antimetabolites, LSL is performed within the first month. When trabeculectomy is done with MMC, it can be effective up to 6 to 8 weeks after surgery. One suture should be cut at a time to avoid overfiltration. There are various lenses available for LSL. Hodgkin's is the most commonly used. The various parameters are 50 microns, spot size, 0.1 second exposure time, and 200 to 500 milliwatt power. So this is a video showing LSL. Ask the patient to look down inferiorly, assess the bleb area, then place the Hodgkin lens, and LSL is done. And then just lateral to the bleb, digital local massage is done if needed. If releasable suture are applied, then it is removed with the help of plain forceps, and then local digital massage is given if required. Videos are not plain. Always do the post-operative gonioscopy to rule out any incarceration of iris, vitreous or dense membrane to the ostium. If present, NDAC laser is done. When all the conservative measures fails, bleb needling is required. The prerequisites for bleb needling: elevated IOP with deep anterior chamber, encapsulation of the bleb or episcleral scarring. There are various antimetabolites injections such as MMC or 5-FU. MMC in a dose of 0.1 ml of 0.4 mg per dl and 5-FU 15 to 50 mg in 3 to 10 injections are given. MMC has been shown more effective than 5-FU. Injection Avastin and injection Lucentis have also been tried, but the results are not that encouraging. So the goal for after bleb needling is to increase the permeability of the bleb wall in order to produce a more diffuse and functioning bleb. This is a video showing a bleb needling. In this, injection mitomycin C is injected 8 to 10 millimeter away from the limbus, and then with the help of 26 gauge needle, fibrous adhesions are broken at the level of subconjunctival and at the scleral bed. Another technique for bleb needling is ab interno bleb needling with Grover's spatula. In this, similar injection mitomycin C is injected, and then by the side port, Grover's spatula is inserted, and the scleral adhesions are broken at the level of subconjunctival and the scleral bed. So bleb needling can rescue a failing bleb, save patient burden from using multiple anti-glaucoma medication and repeat surgery. So early intervention in initial post-operative 4 to 6 weeks is crucial for successful outcome of trabeculectomy surgery. This is my take-home message. Thank you, everyone.
Thank you so much for that wonderful presentation. Dr. Nimrita, how much time do you actually wait in between? Suppose you see a patient post-trab after with a high IOP, and then you tell the patient to do massage. How much time would you wait to do something like a suture lysis or give a subconj 5-FU?
So when the patient presents with high IOP, we start with AGM. If the LSL is not possible because of the high fibrotic tissue, and after 1 month duration, we can do bleb needling, sir. So also on every follow-up, if there are signs of failing bleb such as flat bleb, there is high IOP, so we give the massage and we see how the bleb is working. If it is not raising, then we can do LSL, and if it is not working, then we can give subconjunctival antifibrometabolites.
So you're saying not working,
Means
but I'm asking the time period in between all these procedures. How much time would you wait to see whether one is working or not, and then move on to the next second, and then move on to the third?
So initially we advise patient to follow up every 15 days.
Okay.
So 15 days, and then 1 month. So when it shows the signs of failing.
So if there's high IOP with even after massage, you would leave the patient for 15 days to see whether suture lysis needs to be done or not?
No, sir. We start the first monotherapy. And then we can do the bleb needling, sir.
Thank you very much.